Respiratory failure, Chapter 26, patient-centered care, nursing care, would be to maintain a patient's airway and monitor respiratory status every hour and more often as needed. Mechanical ventilation is often required with positive end expiratory pressure, PEEP, PEEP, or continuous positive airway pressure, CPAP, to prevent alveolar collapse during expiration. Follow facility protocol for monitoring and documenting ventilator settings. Oxygenate before suctioning secretions to prevent further hypoxemia. Suction the client as needed. Assess the document sputum color, amount, and consistency. Assess lung sounds per facility protocol. Monitor for pneumothorax, such as a high PEEP can cause the lungs to collapse. Obtain EBGs as prescribed and follow each ventilator setting adjustment. Maintain continuous ECG monitoring for changes that can indicate increased hypoxemia, especially when repositioning and applying suction. Continually monitor vital signs, including SaO2, and assess pain level. Position the client to facilitate ventilation and perfusion. Prevent infection. Perform frequent hand hygiene. Use appropriate suctioning technique. Provide oral care every 2 hours as needed. Wear protective clothing such as gown, gloves, mask when appropriate. Promote nutrition, assess ball sounds, monitor elimination patterns, obtain daily weights, monitor INO, administer enteral and or parenteral feedings as prescribed. Prevent aspiration with enteral feedings by elevating the head of the bed 30 to 45 degrees. Confirm nasogastric NG tube placement prior to feeding. Provide emotional support to the client and family. Encourage verbalization of feelings. Provide alternative communication means such as dry erase board, pen, and paper. Moving on to medications used would be the benzos, the benzodiazepines. Examples would be lorazepam and midazolam. Actions would be to reduce anxiety and resistance to ventilation and decrease oxygen consumption. Nursing actions are to monitor respirations on clients who are not receiving mechanical ventilation, monitor blood pressure and SaO2, use cautiously in conjunction with opioid narcotics. General anesthesia examples would be propofol, PROPOFOL. Actions are to induce and maintain anesthesia, sedate clients for mechanical ventilation. Nursing actions would be contraindicated for clients who have hyperlipidemia and egg allergies. With the propofol, this action is to induce and maintain anesthesia, sedates clients for mechanical ventilation. Nursing actions would be contraindicated for clients who have hyperlipidemia and egg allergies. Administer only to clients who are intubated and ventilated. This is the sedation effect they need for this. Monitor ECG, blood pressure, and sedation levels. IV rate must be slowed to assess neurologic status. Follow facility protocol. Monitor for hypotension. Titrate to desired sedation. No analgesic actions. Monitor pain and administer analgesics as prescribed. Corticosteroids, examples would be cortisone acetate, methylprednisolone sodium succinate, dexamethasone sodium phosphate. Actions would be to reduce WBC, migration, and decrease inflammation. Nursing actions would be make sure that the medication is discontinued gradually. Administer with an anti-ulcer medication to prevent peptic ulcer formation. Monitor weight and blood pressure. Monitor glucose and electrolytes. Client education would include taking oral doses with food and avoid stopping the medication suddenly. Opioid analgesics are examples of morphine, sulfate, and fentanyl. Actions would be to provide pain management. Nursing actions is to monitor respirations for clients who are not receiving mechanical ventilation. Monitor blood pressure, heart rate, and SaO2. Monitor ABGs. Hypercapnia can result from depressed respirations. High blood carbon dioxide from decreased respirations, which would be hypoventilation. High carbon dioxide. Use cautiously in conjunction with hypnotic sedatives. Assess pain level in response to medications. Have naloxone and resuscitation equipment available for severe respiratory depression in clients who are not receiving mechanical ventilation. Neuromuscular blocking agents are examples: becuronium, atracuronium, and rocuronium. Actions are to facilitate ventilation and decrease oxygen consumption, often used with painful ventilatory modes such as inverse ratio ventilation and PEEP. So IRV and PEEP. Nursing actions are to administer only to clients who are intubated and ventilated, monitor ECG, blood pressure, and muscle strength, give pain medication and sedatives with neuromuscular blocking agents. Neuromuscular blocking agents do not sedate or relieve pain. Clients can be awake and frightened. Have neostigmine and atropine available to reverse the effects of the neuromuscular blocking agent. Have resuscitation equipment available and explain all procedures. So remember, this neuromuscular blocking agent is to facilitate ventilation and decrease oxygen consumption. Client education would be paralysis is medication induced. Antibiotics are other medications used, and there's antibiotics sensitive to cultured organisms, such as vancomycin. Vancomycin treats identified organisms. Nursing action would be culture sputum prior to administration of first dose, monitor for hypersensitivity reaction, give IV doses slowly over at least 60 minutes, 1 hour, to avoid red man syndrome. Monitor the IV site for infiltration. Do not give with other medications. Monitor coagulopathy and renal function. Include client education as to take oral doses with food and finish the prescribed dose. Interprofessional care. Respiratory therapy. The respiratory therapist typically manages the ventilator, adjusts the settings, and provides chest physiotherapy to improve ventilation and chest expansion. The respiratory therapist can also suction the endotracheal tube and administer inhalation medications such as bronchodilators. Physical therapy for extended ventilatory support and rehabilitation. Nutritional therapy, enteral or parenteral feeding, nutritional support following extubation. Therapeutic procedures, intubation and mechanical ventilation. Artificial airway insertion with mechanical ventilation. Nursing actions would be monitor ECG, SaO2, lung sounds, and color, sedate as needed, provide reassurance to calm the client, have suction equipment, manual resuscitation bag, and face mask available at all times. Suction secretions as needed. Pre-intubation would be to oxygenate with 100% oxygen, assist ventilation with manual resuscitation bag and face mask, have emergency resuscitation equipment readily available. Post-intubation, assess and title carbon dioxide levels, bilateral lung sounds, symmetrical chest movement, and chest x-ray findings to confirm placement of the endotracheal tube. Secure the endotracheal tube per facility guidelines and assess the balloon cuff for air leaks periodically. PEEP, positive pressure, is applied at the end of the expiration to keep the alveoli expanded. PEEP is added to the ventilator setting to increase oxygenation and improve lung expansion. Client education is alternate methods of communication will be provided because speaking is not possible while the endotracheal tube is in place.